Well, welcome everyone. Thank you so much for taking the time to join us this evening. My name is Jillian McConnell. I am a knowledge broker with Brain Exchange, and on behalf of my colleagues from the MS Society of Canada, we welcome you and are so pleased to have you able to join us. Today's webinar is the 7th of an 8-part learning series brought to you by MS Canada, and I'll post a link in the chat pod later on if you're interested in finding out more about our past 6 events up until this point. Before we begin, I just want to take a few minutes to review the technology that we'll be using this evening. The audio is provided over the phone, which means if you're hearing my voice, then you're all set. And the visuals or the slides are provided by an online link that you would have received in the connection details, and that way you can watch the slides as our presenter speaks. On the bottom left of your screen, you'll see a blue bubble. If you move your cursor or your mouse over it, you'll see a chat with the presenter box come up. If you click on that, that's how the chat pod should appear. And that is how you can communicate with me during the event as well as with the presenter. I do want to note that only the presenter and I can see your notes in the chat pod, not fellow participants. And that's also where you can send your questions to us during the Q&A portion. I want to make you aware that all of your participant lines have been muted for this call for the time being. That just helps us minimize background noise or private conversations that may be having on the side. If you do need to ask a question or if you have a concern during the actual presentation, then please use the chat pod as, of course, we won't be able to hear you. The presentation itself is being recorded, so within a week or so, we will make it available on the MS Society of Canada's website, as well as on the Brain Exchange website as well. So for the purpose of today, those are really the only features you need to be familiar with. The webinar is scheduled to be 90 minutes in length, and our presenter will speak for about 60 minutes or so total, and then we'll leave the last 30 minutes at the end for some Q&A and hopefully for some discussion. I do ask that people refrain from asking questions for our presenter, Dr. Parks, in the chat pod to wait until the end of the discussion, unless, of course, the question is the end of the presentation, but unless, of course, the question is technology related, and then I'll do my best to help you out. Okay, so now that the technical aspects have been taken care of, I do want to take this opportunity to review a few bits of information that the MS Society of Canada has asked that I share with you on your behalf. So the MS Society of Canada Ontario Division, in this case, but we certainly provide this with everyone, with the Nova Scotia Division as well, wishes to gratefully acknowledge the educational grant received from Biotin, which makes possible the Feast of Dietary Advice in Multiple Sclerosis session. The MS Society does not approve, endorse, or recommend any specific product or therapy, but provides information to assist individuals in making their own decisions. And the identification of needs, determination of objectives, selection of content and speakers, educational methods, and materials are the sole responsibility of MS Society staff and advisors. They also asked that I review very quickly the mission statement of MS Society of Canada, and that is to be a leader in finding a cure for multiple sclerosis and enabling people affected by MS to enhance their quality of life. And so now it is my great pleasure to introduce our webinar topic and our presenter for this evening's event. As I mentioned, today we'll be speaking about Feast of Dietary Advice in Multiple Sclerosis, and we're so very pleased to have Dr. Natalie Parks with us today to present. Natalie Parks is a native Haligonian who has recently joined the Division of Neurology at Dalhousie University as an assistant professor. She completed her MD with distinction, receiving the Dr. C.B. Stewart Gold Medal in Medicine in 2011 and neurology postgraduate training in 2016 at Dalhousie. She is a fellow of the Royal College of Physicians and Surgeons of Canada and has electromyography certification from the Canadian Society of Clinical Neurophysiologists. Dr. Parks completed a multiple sclerosis fellowship at the Mayo Clinic in Rochester in 2017 and was appointed Assistant Professor of Neurology at the Mayo Clinic College of Medicine. So we're very pleased to have her on the line with us today. So Dr. Parks, welcome, and the floor is yours.
Great. Well, I want to thank everyone for joining us tonight. You know, I'm new to practice as a neurologist in the field of multiple sclerosis, but one of the things that I've noticed when I meet with patients in clinic is that diet advice and information about supplementation of diet with vitamins is something that generally comes up. it's an area that, unless the question is asked, it might not get addressed. And so I wanted to hold this forum tonight to communicate a little bit more of what I know about diet and supplementation in multiple sclerosis. I want to make it clear to everyone that this is from a neurologist's perspective. I'm not a dietitian, and so that likely will influence the content of what's presented. What I want to communicate is the evidence behind certain diets and evidence for supplementation that's out there. So we might not go into a lot of detail about some of the diets in terms of exactly what you should be eating, but the evidence behind the topics that I'm going to address tonight. So tonight's discussion is going to focus on how does body weight affect multiple sclerosis. So there's actually a lot of research that's out there on that topic, and it turns out that body weight probably does have a significant impact on risk of multiple sclerosis, at least during certain phases of your life. We're also going to talk about how does diet influence multiple sclerosis, and is there anything that you can supplement your diet with to perhaps reduce your risk of multiple sclerosis or the severity of multiple sclerosis if you're already diagnosed. So to address the first topic, body weight and multiple sclerosis, so the first thing to know about body weight is that it can be quantified in terms of body mass index. So that's a standard way of communicating how your weight compares to your height. And if you look at this graph here, you can see that height is on the y-axis and weight is on the x-axis. And so the greater your weight compared to your height, the higher your body mass index. So in general, normal would be below 25 if you're getting down to under 18.5, that's underweight. But then overweight would be 25 to 30, and quite overweight or obese would be over 30. So that's a way of quantifying how much do we weigh and what is the relationship of weight to height. So it turns out that when we look at weight in terms of body mass index, there is a strong association between being overweight or obese, particularly during the adolescent years, and risk of multiple sclerosis. So where did that information arise? Well, one of the studies that derived that information was conducted in Denmark and in Copenhagen. So many of the Scandinavian countries have great database systems where they're able to collect information from many, many people in the population. And in Copenhagen, researchers looked at 300,000 school records from children that were enrolled in school who were between the ages of 7 and 13. And what they found was that increased BMI was associated with an increased risk of multiple sclerosis. They found particularly that a 1-unit increase in BMI in terms of a Z score, which is a standard deviation from the mean, was associated with an increased hazard ratio that was significant, so it didn't cross 1. They found that that effect was more significant in girls than it was in boys. So what they found from this information was that being overweight or obese, particularly for a girl, was associated with a slightly increased risk of developing multiple sclerosis later on.
Dr. Parks, can I just interject and just ask you possibly to speak up slightly louder? We're just having a few people who can't hear you as well as we might like you to be able to be heard.
Oh, sure.
Thank you.
The next slide deals with a Californian cohort. So this was a group of almost 1 million patients who were followed in California. And of those, there were 75 cases of multiple sclerosis or a first attack of multiple sclerosis, something referred to as a clinically isolated syndrome or CIS, amongst those approximately 900,000 people. And so the CIS and MS cases that they looked at were all under the age of 18 years. What you can see from the graph is that for boys, the risk really wasn't changed based on weight. So if you look at the top part of the graph that says boys, and you look to see are they under or normal weight, you can see that the dot is placed at 1. So that's the risk that they're measuring against. And all of the weight categories, overweight, moderate obesity, and extreme obesity, all of those averages with their standard error cross the line of 1. So that means that they're not significant. So for boys, there wasn't a very strong association between being overweight and having an increased risk of multiple sclerosis. But if you look at the lower part of the graph for girls, you can see that, again, underweight and normal weight was judged as the reference. That's the one that everything else is measured against. So for overweight girls, so those would be the girls with the body mass index between 25 and 30. You know, the mean for them was slightly higher, but it still crossed 1, so it's not significant. Same goes for those with moderate obesity. But for those with extreme obesity, having a BMI of greater than or equal to 35, you can see that they were at increased risk of developing multiple sclerosis later on, and a fairly significant increased risk when you look at the odds ratio. It was 3.76, meaning they have almost a 4 times increased chance of developing multiple sclerosis compared to girls of normal weight. Further work has been done in the form of case control studies. There was work done identifying 254 patients under the age of 18 years and finding 420 age-matched controls. In this case control study, what they found was that, again, there was a larger effect in girls than there was in boys in terms of the interplay between weight and risk of multiple sclerosis. So among the girls, 54% of girls with multiple sclerosis were either overweight or obese, compared to 33% of the control population. For boys, 48% of the boys with multiple sclerosis were overweight or obese, compared to 34% of the controls. Now, if you're familiar with statistics, then you can see the p-value over here is significant for girls. So there was a statistically significant difference in the number who were overweight amongst the group with MS compared to the group that were the control group. For boys, the relationship was not statistically significant. But overall, what they found in their regression model was that higher BMI was associated with greater risk of MS. It was most significant for postpubertal girls, but in this way of looking at the data, there was also a small increased risk for boys as well. So up to this point, we've talked about the association between increased BMI, so being overweight or obese as a child or adolescent, and future risk of multiple sclerosis. So it definitely seems that there is a relationship between being overweight or obese as a child, particularly if you're a girl, and having an increased risk of multiple sclerosis in the future. But what about if you are an adult? Is there any relationship between your weight and risk of multiple sclerosis? So interestingly, this issue was addressed in a large study called the Nurses' Health Study that looked at thousands of individuals, and they looked at weight at 18 years, but they also looked at weight a number of years later as an adult. And what they found was that obesity at age 18 years was associated with an increased risk of multiple sclerosis. In fact, it was associated with a 2 times increased risk but that there was no association between adult weight and risk of MS. So that's very interesting. It seems to be that weight before the age of 18, so as a child or adolescent, is more influential in your risk of developing multiple sclerosis later on. And it seems to be that girls are more susceptible to this than boys. In various studies, there has been a relationship noted between increased weight and risk of MS in boys, but the relationship seems to be a stronger relationship in girls. So the take-home point for this is that childhood and adolescent high BMI, so being overweight or obese, is associated with increased risk of MS. There's strong evidence for this amongst girls and some mixed evidence amongst boys. The mechanism of the association between obesity and MS risk remains unknown, but there are some theories behind that, and that could be that being overweight, that having more fat or adipose tissue leads to being in a pro-inflammatory state, that your body is more inflamed or inflammatory. And there's also work done to show that, if you're overweight or obese, you might have a lower level of vitamin D. But that's a little bit tricky to understand because it's hard to know what comes first. Do you have low vitamin D because you stay indoors and you're not as active and not as exposed to sunlight as other people who might get out in the sunshine more often? So the advice for body weight is, although evidence for the association between obesity and MS is best established for childhood and adolescent weight, it is still a good idea to maintain a healthy weight, so a normal BMI. So that would be between 18.5 and 25. And that's something that you can ask your doctor about if you're not sure how to calculate that. But it's basically weight over height, so weight in kilograms over height in meters squared. So between 18.5 and 25 would be considered a normal BMI, and that can be achieved through diet and exercise. Really, the best recommendation for how to achieve a healthy BMI would be to follow Canada's food guide, so to have a healthy, balanced diet, and then also to follow Canada's physical activities guideline, which recommends that adults should accumulate at least 150 minutes of moderate to vigorous intensity aerobic exercise every week in bouts of at least 10 minutes. So that can be lots of different things, but something that accelerates your heart rate a little bit and gets you doing aerobic exercise in 10-minute intervals. So now on to the next part of our talk, which is diet and MS. We're going to address a couple topics here. We're going to look at sodium, polyunsaturated fatty acids, and then some specific diets that have been devised for multiple sclerosis. So sodium, the World Health Organization has strongly recommended that daily consumption of sodium should not exceed 2 grams per day. And so there's lots of reasons for that. It can affect your cardiovascular health, but does it have an impact on multiple sclerosis as well? So there is evidence to suggest that sodium promotes a pro-inflammatory state. So as you can see from this diagram, sodium can have an effect in upregulating a number of cells and molecules which might be involved in the development of multiple sclerosis. So it might upregulate T cells, increase macrophage activity, and increase permeability of the blood-brain barrier. So those are all things that could predispose to multiple sclerosis or increased multiple sclerosis activity potentially. So there is some work that's been done in terms of salt consumption and multiple sclerosis activity. So in one study, they looked at 70 patients with multiple sclerosis, and they measured or they estimated their daily sodium intake based on urine samples. In this study, what they found was that there was a direct relationship between the amount of salt consumed per day and the risk of relapses. So basically, if you consumed less, or the recommended amount of salt per day, so less than 2 grams per day, that was the reference point. If you consumed a little bit more than that, 2 to 4.8 grams per day, you had a higher risk of having relapses. And if you consumed over 4.8 grams per day, you had an even higher risk of relapses. So there was a linear increase, and there was a positive relationship here between the amount of sodium consumed and the number of relapses experienced by multiple sclerosis patients. The same study also correlated salt intake to MRI activity. Again, there was a positive relationship between the amount of salt consumed and new activity on MRI. So that could be new T2 lesions or enhancing lesions, but basically more inflammatory lesions on imaging, more MS lesions on imaging. So if you were at less than 2 grams per day, that was considered the reference point. If you ate a little bit more salt than that, you were at about twice the increased risk. And if you ate the greatest amount of salt per day, so more than 4.8 grams, you are at the highest risk of having new MS lesions on imaging. So it's interesting that the study that we just looked at found a very strong and positive association between salt consumption and multiple sclerosis activity, both in terms of relapses and MS lesions on imaging, because other work has been done, this time in a sample, it's a larger sample of 465 patients with a single MS attack. So these patients had clinically isolated syndrome, and they used similar methods for estimating the amount of salt intake per day. They looked at urine samples to decide how much salt an individual consumed. And in this study, it was the exact opposite results of the prior study. They found that there was no association between salt intake and several different measures of multiple sclerosis. So because these people had a first attack of multiple sclerosis, it was clinically isolated syndrome. They looked at conversion to definite MS. They looked at relapse rate, EDSS progression, and new lesions on MRI, and they didn't find any association between salt intake and any of those outcomes. So in this study, it looked like sodium intake was not related to multiple sclerosis activity. So that's interesting that there's a mixture of evidence out there from different studies, and so it's difficult to conclude at this point whether there is a definite association between salt consumption and MS activity. But it would still be recommended that individuals with MS follow the World Health Organization recommendation to consume less than 2 grams of sodium per day. And that's going to be beneficial for your overall health, including cardiovascular health, even though it might not have a direct effect on multiple sclerosis. The next topic to address under diet is polyunsaturated fatty acids. So these are the types of fats in your diet that are referred to as omega-3 and omega-6 fatty acids. And it's interesting because omega-3 fatty acids, I usually associate those with fish oils, but they also come in from other foods as well. So the three main fatty acids that we'll talk about in the studies that follow would be alpha-linolenic acid, which is actually a plant-derived omega-3 fatty acid, and that can be derived from various vegetarian sources. So flax, walnut, and soybean would all contain that plant-derived omega-3. The marine or fish-derived oils would be eicosapentaenoic acid and docosahexaenoic acid, which are your typical are typically derived from cod liver oil or salmon. So maybe what you associate more frequently with omega-3 fatty acids. And polyunsaturated fatty acids are important because they are involved in the inflammatory cascade. So it's interesting that arachidonic acid is a fatty acid that's highly involved with inflammation. So the fatty acids do play a role in inflammation in the body. The Nurses' Health Study, which we talked about a little bit about before, had 175,000 participants, including 479 cases of MS. And they actually looked at consumption of fatty acids using a food questionnaire. And what they found was that the higher your consumption of fatty acids, the lower your risk of multiple sclerosis. So that's an association. It doesn't imply causation, but they found that there was a substantially decreased risk of multiple sclerosis among individuals with the highest consumption of fatty acid. They looked at that a little further to try and determine whether it was the plant-based fatty acids or the marine-based fatty acids. And they looked at the fatty acids we just talked about, so alpha-linolenic acid and the marine-derived acids. And they found that it was the plant-derived fatty acid that was the only one that was significantly correlated with MS risk. So the higher your level of alpha-linolenic acid, so consumption of soybean and walnut, because they found they derived this information from a food questionnaire, the lower the risk of MS. Interestingly, they didn't find an association with the marine-derived fatty acids. Another study looking at 267 multiple sclerosis cases with 517 age-match controlled also looked at fatty acid consumption using a food questionnaire. Again, they found that higher consumption of fatty acid was associated with a lower multiple sclerosis risk. But this time, it's interesting that they found the reverse for the type of fatty acid that was inversely correlated with multiple sclerosis risk. So in this case, they found that it was the marine or the fish-derived fatty acids that resulted in a lower MS risk. So the higher your consumption of cod liver oil and salmon, because again, this was derived from a food questionnaire, the lower your risk of multiple sclerosis. And they didn't find a relationship between risk of MS and the plant-derived fatty acids. There's also been a randomized controlled trial in this area with 92 multiple sclerosis patients who were randomized either to a fish oil capsule, so like a cod liver oil tablet, versus placebo. And interestingly, even though there was population level data on an association between higher levels of fatty acids being associated with lower risk of multiple sclerosis, there was no difference in multiple sclerosis activity in this randomized controlled trial. So when they took these 92 multiple sclerosis patients and gave half of them fish oil tablets and half of them placebo, they didn't see any difference in terms of new multiple sclerosis lesions on imaging or relapses or disease progression when they followed these patients over a number of months. So overall, what is the evidence for fatty acids? Well, the American Academy of Neurology, which is a very respected source of guidelines, says that fish oil supplementation is probably ineffective for reducing multiple sclerosis-related activity. So at this point, there's insufficient evidence to make a recommendation regarding polyunsaturated fatty acids. Certainly, there's no strong evidence to recommend supplementation in that area. So now, an overview of some of the diets that have been used in multiple sclerosis, including the Paleolithic diet, the Swank diet, and the McDougall diet. So the Paleolithic diet is based on a hunter-gatherer type of diet. So what our ancient ancestors likely would have eaten, which would be a diet based on vegetables and fruit and lean meat. So it would be food that's not cultivated, but food that basically grows in the wild. And it would be a diet that avoided a lot of foods that you can basically imagine growing on farms or being raised under controlled conditions. So It excludes typically gluten, dairy, and eggs. Now, in terms of what is the evidence for this in multiple sclerosis, when you look at the evidence-based trials that are out there, there's not a lot of research that's been rigorously conducted on the Paleolithic diet. In fact, in my analysis of the literature, I was only able to find one trial looking at the Paleolithic diet. So this was a single-arm open-label trial, which means that they recruited, in this case, 10 secondary progressive multiple sclerosis patients, and all of the patients received the same treatment, and they were all aware of the treatments that they were receiving. So it wasn't placebo-controlled, it wasn't blinded. Everybody got the same treatment, and everybody knew what they were receiving. So of these 10 secondary progressive multiple sclerosis patients, all received multiple interventions. So one of the interventions was the Paleolithic diet, but they also received other complementary forms of therapy, including advice regarding exercise, electrical stimulation, and massage therapy. Interestingly, the outcome that was measured wasn't one of the typical multiple sclerosis outcomes used in clinical trials like relapses or progression or new lesions on MRI. It was a measure of fatigue severity. But what they did find in this trial is that compared to the outset, the beginning of the trial, 12 months later after having multiple interventions, including the Paleolithic diet, patients felt less fatigued than they did at the study initiation. With these types of trials, it's difficult to take away concrete conclusions because there's no comparator group. It's not randomized. They weren't randomly selected to go into one group versus another, and there's no comparator. Also, the fact that these 10 patients were closely monitored over the course of the year and received lots of extra support could be the reason that they felt less fatigued at 12 months, and it might not necessarily be attributable to any one factor, any one intervention they received, and certainly it would be difficult to say that their decrease in fatigue was solely related to the Paleolithic diet. The next diet is the Swank diet. So the Swank diet is one that advocates for a diet low in saturated fats. And the researchers, Dr. Swank, thought that a good target for being low in saturated fat was less than 20 grams per day. This is a very interesting cohort because they have, at this point, 50 years of follow-up on patients that were started on the Swank diet. This was a study that was initiated back in the 1940s and 1950s at the Montreal Neurologic Hospital, and they've been followed up now to some of them for 50 years. At this 34-year point, there were still a fair number of MS patients still enrolled in the trial. So 34 years after they had started the Swank diet, 144 remained in the trial. And what they found was that particularly those that were the good dieters, so that would be 70 out of the 144, had an increased rate of survival compared to those that didn't adhere to the diet as closely. So you can see that in the group that had less than 20 grams of fat intake per day, about 33% of that group was deceased at 34 years. But in the group that didn't adhere to the diet as closely, so they consumed more than 20 grams per day of fat, 80% were deceased. So again, this is not a trial that's a randomized control trial where there's randomization to one diet versus another versus a control, where you're able to attribute just the intervention to the change in outcome. So in this case, people kind of self-selected as to whether they were going to strictly adhere to the diet or not, and that could be responsible for some of the differences in mortality that were observed down the road at almost 30 years after the diet was initiated. So again, difficult to draw conclusions from this type of study. The McDougall diet is another diet that advocates for very low fat with a plant base. So meat and fish, eggs, and dairy are prohibited. There has been a randomized control trial conducted on the McDougall diet. So in this case, 61 multiple sclerosis patients were randomized to the McDougall diet versus no dietary advice. And what you can see from the graph here is that the patients that didn't receive dietary advice, basically their percentage of calories that they consumed as fat didn't really change over the course of the trial. So they, at baseline consumed about 40% of their calories as fat, and that just remained constant over the course of the study. But for patients that received the intervention, so they were counseled on the McDougall diet, they went from obtaining about 40% of their calories of fat down to 10 or 15%. So there's a dramatic reduction in calories achieved from fat. So they were, on the whole, adhering to the diet and reducing their fat intake. Interestingly with this, at 1 year, there was no significant difference in multiple sclerosis activity based on the traditional measures that are traditionally measured in MS trials for MS activity, such as relapses, progression, and new MS lesions on imaging. So this was a randomized control trial, so pretty rigorous study in terms of the types of research evidence. And this randomized control trial did not show a benefit in terms of multiple sclerosis activity from being on the McDougall diet. So overall, in terms of diets for multiple sclerosis, there's not a lot of rigorous evidence to support any single diet that's been devised for multiple sclerosis. So there hasn't been rigorous evidence to show a benefit in multiple sclerosis of any of the three diets that we talked about, the Paleolithic diet, the Swank diet, and the McDougall diet. So now on to supplementation and multiple sclerosis. So vitamin D is probably something that everyone has heard about, the association between higher levels of vitamin D and lower risk of multiple sclerosis. So that's something that's widely been observed around the world in observational studies. You can see from this graph that the higher your levels, like the higher the category you fit into in terms of blood level of vitamin D, the lower your risk of multiple sclerosis. So that's something that's been observed at the population level quite frequently. So vitamin D is something that can be derived both from the diet and from the sun. So vitamin D comes from basically a reaction, a downstream reaction from the sun manipulating cholesterol through UV rays. So you can get increased level of vitamin D in your blood through exposure to sunlight, but then also absorption through the gut. There have been some randomized control trials, so high quality evidence looking at supplementation of vitamin D. One of these trials was called the SOLAR trial, and it was a small pilot of a larger trial whose results aren't completely known yet. But the small pilot part of SOLAR involved 23 multiple sclerosis patients, and they were given vitamin D 13,000 units a day compared to 1,000 units a day for 6 months. The ones on the higher amount of vitamin D actually initially started at 13,000 units, but then as the study went on, they were given recommendations of how to adjust their dose of vitamin D to reach a target level of vitamin D in the blood. At 6 months, they didn't find any relationship between whether you were on the high dose of vitamin D or a low dose in vitamin D in terms of multiple sclerosis activity. So there was no difference in terms of MS lesions on imaging, relapses, or progression. But keep in mind that this trial was only for 6 months. So vitamin D likely acts on genes. It likely modulates genes that are involved with inflammation, and that might be a process that takes place over a much longer period than just 6 months. It might be something that takes years. So it's difficult to know whether maybe this trial just didn't follow patients or treat patients with vitamin D long enough to see an effect. The other issue is it's a very small trial. It only has 23 patients. And SOLAR did actually recruit more patients in the long-term study, but the results of that have not been published yet. There's another randomized controlled trial that's occurring in the United States, and that's called VDAMS, Vitamin D to Ameliorate Multiple Sclerosis. And that has currently recruited 172 multiple sclerosis patients who have been randomized either to vitamin D 5,000 units per day or 600 units a day, and they followed for almost a 2-year, and they're being treated and monitored for a 2-year period. So that's 4 times longer than the study we just looked at that only monitored patients and treated patients for 6 months. So VDAMS is currently underway in the United States, and again, the results of this randomized control trial for vitamin D and its effect on multiple sclerosis are not published yet. But in terms of supplementation, what are the recommendations? So, you know, it's interesting the amount that's recommended in multiple sclerosis compared to what's recommended in some of the dietary literature, which is much lower in terms of your daily allowance or what the minimum daily allowance should be. So the Institute of Medicine would say that the recommended daily amount of vitamin D just for the average person would be about 600 units through most of adult life, and that the upper limit of their recommendation would be 4,000 units. The Endocrine Guideline Practice Committee has slightly different recommendations. They have a slightly higher level for both the daily allowance and the upper limit, with a recommendation for the daily allowance for the typical person being between 600 and 2,000 a day, and the upper limit being 4,000 to 10,000 a day. But those are for the public in general and not necessarily people with multiple sclerosis. So in terms of what dose of vitamin D should the typical patient with multiple sclerosis be taking? Well, there is evidence to suggest that there's a lower risk and lower activity of MS associated with a serum or a blood vitamin D level greater than 100 nanomoles per liter. And guidelines that have been released have suggested that that level in the blood can be achieved by taking a supplement of vitamin D between 2,000 and 4,000 international units per day. So in general, we recommend to multiple sclerosis patients at our clinic that they take vitamin D 4,000 units a day. In general, individuals who live in Canada do have a slightly low dose of vitamin D in their blood at baseline, and there's not a lot of harmful side effects from taking vitamin D. I mean, there are some risks, like increased risk of kidney stones, but the general recommendation would be vitamin D 4,000 units per day. The next topic I'd like to address is supplementation with biotin. So for biotin, the typical daily intake is 30 to 100 micrograms per day. So biotin is a cofactor for enzymes that are involved in fatty acid synthesis, and having increased levels of biotin may actually facilitate or improve the repair of myelin, which coats nerves and which is broken down in multiple sclerosis. So having higher level of biotin might increase fatty acid synthesis and repair of myelin on neurons. There has been a randomized control trial looking at very high dose biotin in 154 patients with progressive multiple sclerosis. So these were both secondary progressive multiple sclerosis and primary progressive multiple sclerosis patients, so both. And they had fairly significant disability. I don't know if you're familiar with the EDSS score, but it was between 4.5 and 7, 7 meaning that they could be disabled to the point of requiring a wheelchair. In this trial, patients were randomized to biotin 100 milligrams 3 times a day versus placebo for 12 months. So keep in mind that in the prior slide, the recommended daily allowance for biotin was 100 micrograms. So that would be 0.1 milligrams. So this is 1,000 times that dietary recommendation, or actually 3,000 times because you're taking 100 milligrams 3 times a day. So the primary endpoint of this trial, where they were randomizing progressive patients to biotin 100 milligrams 3 times a day versus placebo for 12 months, was actually a very difficult to achieve endpoint, which is disability reversal. So they were looking for not just their disability to stabilize, but for it to actually improve. And they looked at that at 9 months and then confirmed it again at 1 year. So what you can see in this graph is that at 9 months, confirmed then at a year, basically 13% of the group that received the biotin actually met the outcome of having improved disability. So they met the criteria for how they defined improved disability. And that was compared to nobody meeting that criteria for improved disability in the placebo group. Then they entered after 1 year into an extension phase where the patients that initially received the biotin continued to receive biotin, but the patients that for the first year received just placebo then received biotin for the second year of the study for the next 12 months. And what they saw was that at month 18, more patients, there were pretty much a constant number of patients in the biotin group that were experiencing improved disability, but you started to see patients that had initially been on placebo and switched over to biotin, they were starting to see some improvement in disability as well. And if you followed it out a little further to 24 months, there were even more patients in the biotin from the beginning group that were seeing improved disability, and more patients in the crossover group who had initially received placebo but later received biotin who were experiencing disability improvement. So these are very interesting results, suggesting that biotin may actually reverse to a certain degree progression. So this is just based on a single trial. That you always have to be careful about drawing firm conclusions from a single study. And that's why there is currently a multi-center randomized control trial being conducted on the effect of high-dose biotin in progressive multiple sclerosis. So this trial is recruiting secondary progressive and primary progressive patients who have still a significant level of disability, but a little bit less severe than the prior trial. And they're doing the same treatment of biotin 100 milligrams 3 times a day versus placebo with the same endpoint of looking for disability progression. And this is a trial that's actually currently underway at a number of Canadian centers. I know that our center is participating. And if you're interested in this, you can always look on clinicaltrials.gov for further details and find out whether your local MS center is participating in this trial. So that's a run through of diet and supplementation and how it relates to multiple sclerosis. We covered the main topics for which there's evidence or reviewed the evidence for a number of different issues, including how does body weight affect multiple sclerosis or risk of multiple sclerosis? Are there any factors in diet that can be modified to change multiple sclerosis risk? And what are some of the what's the supplementation advice that's out there? And so for that, we basically reviewed vitamin D and biotin. Again, I'm not a dietitian, so we didn't go into the details as much about exactly what your diet on a daily basis should look like, but we're looking at the evidence of how and how it stacks up for how do these interventions affect multiple sclerosis. So I'd like to open the floor for questions, and I hope you enjoyed tonight's talk.
Thank you very much, Dr. Parks. Before we get started in that, I do want to just remind our participants on the line here how that they may address some questions with you. There's two methods in which you can ask a question. The first being to type your question into the chat pod, which we've already had a few interested parties do so already. And just as a reminder, only Dr. Parks and I can see the questions that you've posted in the chat pod, so they are anonymous, and I will not be revealing any names whatsoever. So you do have that anonymity. The other option would be to unmute your individual line and ask your question over the phone. So obviously, only those who are interested in asking over the phone, unmute your line, because otherwise it will get really noisy really fast. But if you do wish to ask in that way, just press *7 to unmute your line. And I do want to remind people as well, for those who are new to this or haven't participated or it's been a while, we do ask some poll questions at the end or during the Q&A part. So those will be popping up tonight, and I'm going to put the first one up right here so you can see what I'm talking about. So I do invite you to stay for the duration of the poll questions as well. And also, of course, you're going to get lots of great little information from the Q&A. And there's about 5 or 6 questions, so please, if you would take the time to respond to those. Okay, so now that all being said, we'll jump right into the questions here. So the first question that this individual had was specifically about biotin, and I know we have to be careful about getting too specific, but she's asking about her son, who is 24 years old, has RRMS, and was just wondering, sort of ballparking if you can provide this information of how much biotin he should be taking, can it reverse disability, and where is the best place to get it?
Mm-hmm. So first of all, in any particular scenarios, I'd always recommend talking to your treating neurologist. But in terms of a young individual with, I believe you said RRMS, so relapsing remitting MS, I have not come across evidence that biotin has been used for relapsing remitting multiple sclerosis patients. The evidence right now for its use is basically in the progressive forms of MS, so either primary progressive or secondary progressive. And the patients that were enrolled into the trials looking at biotin actually had fairly significant disability. So in the published trial, they had an EDSS of 4.5 to 7, meaning that they wouldn't be able to walk very far unassisted, or they might even be disabled to the extent where they require a wheelchair and they can't stand up independently from their wheelchair. So at this point, biotin's been used for patients with progressive forms of multiple sclerosis, and I'm not aware of any evidence to support its use in relapsing remitting MS. The other issue with biotin is that even though there's one study that looks quite promising, biotin right now is not a standard recommendation in multiple sclerosis clinics. I think a lot of clinicians they don't want to adopt something that looks too good to be true. They want further studies to confirm the results of the previous trial, and that's why we are presently in the process of conducting a multi-center trial on high-dose biotin. So I would encourage anyone that's interested in high-dose biotin for treatment of progressive multiple sclerosis to visit clinicaltrials.gov and find out if there's a local multiple sclerosis center that's participating in that trial, and that might be a way of accessing biotin.
Thank you very much. So we're going to, Dr. Parks, just bear with me. I try to group the questions in somewhat of a fashion, but they do tend to go all over the place. So we're going to jump to the use of carbohydrates. And this individual asks, as carbohydrates are associated with general inflammation, have any studies been done on a grain-free, high-fat, i.e. healthy fat diet?
Well, in terms of carbohydrates, I know I've been asked in the past about whether gluten is specifically has a negative effect on individuals with multiple sclerosis. And I would say no, that's not an association that I'm aware of, an association between gluten and risk of multiple sclerosis or increased multiple sclerosis activity. Certainly if someone had symptoms of celiac disease, I would encourage them to be tested for that, just as any individual should be tested. But there's no increased risk or association that's been described between having multiple sclerosis and a celiac disease. The type of diet that you're describing, so with a limitation on carbohydrates and low in fats, I guess that could conform to a number of the diets that I talked about this evening. The Swank diet, it doesn't have a restriction on carbohydrates, but it does promote very low saturated fat. But like I said, that diet, there is a 50-year observation of a cohort that suggests the group that ate less fat had improved survival. But it's an observational study, which means that we can't extract direct results from that and say that it was the diet that caused the improved survival, because there's many factors that might have gone into the self-selection of those patients that stuck with the diet for 30 to 50 years, basically.
Okay, thank you very much. Okay, so moving on, what is the role of functional medicine in treating autoimmune diseases like MS?
Could the person that asked the question clarify what they mean by functional medicine?
I'll wait for them to jump in here. See if I see anything. Maybe I'll give them time to respond, and we'll jump to the next question. How's that?
Sure.
Okay, this one, changing gears here. I have heard vitamin K can also help with brain repair. Do you know if this has been studied?
So I have not come across vitamin K in the multiple sclerosis literature, not to my knowledge. Typically, I've heard about vitamin K in terms of coagulation disorders, but I'm not familiar with a role for vitamin K in neuroinflammation or in multiple sclerosis.
Okay. All right. I haven't heard back yet from that person regarding. Oh, okay. Here we go. In Google, you can find functional medicine doctors mostly in the U.S., but there are doctors here in Canada too, they say. But they don't really go on to describe functional medicine.
Certainly, I guess when I think of function, I think of physical medicine and rehabilitation, so physiatrists, and there certainly be a role for physiatrists in the treatment of multiple sclerosis. So if you have difficulties in terms of function, so difficulty walking, you need assessment for whether or not you could benefit from a cane or a walker, whether you need treatment for spasticity, maybe Botox to loosen up your limbs if you have a lot of spasticity. Those are all areas that a physiatrist would address, and they help improve function. So perhaps that's what the listener was asking.
Okay. There's been a few questions with respect to the WALS protocol. Have you done much research on that, or care to elaborate a little bit more on the WALS protocol?
So like I say, I'm not a dietitian, so I wouldn't be able to go into the details of exactly what the WALS protocol entails in terms of how many green vegetables or orange vegetables or sulfur-based vegetables. But I certainly would say that it's based on a Paleolithic model for diet. And as we discussed in the talk, there's not a lot of rigorous research that's been done on the Paleolithic diet. And in fact, the only study I was able to come across was the observational study of 10 secondary progressive multiple sclerosis patients who all received the same interventions, and there were multiple interventions, with the Paleolithic diet being one of those multiple treatments that they received. So it's difficult in that circumstance to be able to comment on the effectiveness of those sorts of diets when there's not really rigorous evidence that's out there to kind of catalog their effect. So in the case of the study that's published, when everybody receives the same treatment, that's a problem, because then you don't have a comparator group, a random selection of the same population who didn't receive the intervention to see how they were going to do at the follow-up time anyway. In the study that's out there, they received multiple interventions, so it wasn't even just the Paleolithic diet that they were looking at. It was the Paleolithic diet plus a bunch of other complementary medicine interventions. And then the other issue with it has a very interesting outcome measure in terms of measuring fatigue at the follow-up point versus baseline. And yes, the patients that partook in the study did experience an improvement of their fatigue, but it's difficult to say exactly what contributed to that.
Great. And so I'm not going to belabor the point, but we have had some people follow up with that whole functional medicine comment. So I do want to just interject and mention that one individual saying, it's a person that, from medical community that focuses on supplements, paleo diet, a cell-based metabolism with mitochondria, et cetera, medical practice or treatments that focus on optimal functioning of the body and its organs, usually involving systems of holistic or alternative medicine. So there we go.
Okay.
So we can leave it at that.
Great.
Good to know. See what you learn here. Okay, so there's a comment or a question, I guess, having to do with the chances of a patient with ulcerative colitis developing MS, and whether that's linked in any way.
Right. So even though multiple sclerosis is considered an autoimmune disease, that's the best explanation that we have to this point about the underlying pathophysiology of what causes MS. MS doesn't behave like a lot of other autoimmune diseases, where if you're predisposed to having one autoimmune disease, you have a higher risk of another. With multiple sclerosis, there really isn't an increased risk of some of those other autoimmune diseases. So in general, there is no association between multiple sclerosis and other autoimmune conditions like ulcerative colitis or vitiligo or thyroid conditions. It's one of the exceptions in terms of an autoimmune disease that isn't linked to a higher risk of other autoimmune diseases. There is a slightly increased risk of myasthenia gravis, it's very slight, and apart from that, not really linked to higher incidence of other autoimmune conditions.
Thank you. So moving on, so this person's asking about looking into dietary trials, whether you recommend them. The University of Iowa is recruiting for a trial comparing the Swank diet with the Walls protocol, which is similar to the paleo diet with some adjustments. And so she wants to know sort of whether you would recommend getting involved in something like this, and what questions or criteria would you use to assess whether or not a trial is appropriate or well constructed?
Mm-hmm. Well, first of all, I would check on clinicaltrials.gov, because all randomized controlled trials that are being run officially around the world should be registered on that site. So that would be the first thing, would be to look at whether the trial is registered on clinicaltrials.gov. Not knowing the individual or the trial specifically, I couldn't make a recommendation one way or the other. But I would say to make sure that there's not going to be any harm incurred to the individual by adopting any of the practices that would be required for the trial. And then following up with their local practitioners to see if that's something that they would support their participation in the sort of trial that they're considering.
Thank you. Okay, the questions are coming, so I appreciate your willingness to deal with those rapid fire, Dr. Parks, so thank you. Okay, so another question, has there been any studies on people with MS and being on a Candida, Candida, free diet? Why or why not?
That one I'm not completely sure about. There's certainly been some research over the years into whether introduction of parasites or whether a person has been exposed to parasites, or introduction of parasites influences multiple sclerosis risk. But Candida is basically a yeast. I haven't heard of that one before. I haven't heard of research being conducted with yeast in the diet or not. So I don't have an informed opinion.
Fair enough. Okay, so there's a few questions about the new proposed food guide that we have in Canada, which tends to be a little bit more plant-based and with a decrease in the amount of dairy that we're supposed to have every day. Could you or would you comment on your thoughts about that and how it reflects back to MS?
So definitely, I think that following Canada's food guide is very important. And if individuals have specific questions about whether their diet is adhering to that, I would certainly encourage them to speak with a dietitian to review their diet and make sure that it's following the Canadian food guide recommendations. But in general, yes, I strongly support multiple sclerosis patients following Canada's food guide. That's pretty much the best evidence that we have in terms of a healthy, well-balanced diet for any individual, not just individuals with MS. So I would strongly support individuals, with or without MS, following Canada's food guide. And really, that's to promote overall health, not just your multiple sclerosis risk, but just overall health. And the other aspect that it brings into play is the interplay between weight and multiple sclerosis. So the evidence that's out there right now suggests that being overweight or obese, particularly as an adolescent, is associated with increased risk of MS. Now, there hasn't been a strong association shown between your adult weight and multiple sclerosis activity or risk. But I think that just because we don't have that as a piece of research evidence right now, I think that overall being a healthy weight is only going to benefit your health, and Canada's Food Guide is a great way to have a healthy diet to achieve a normal weight, along with regular exercise.
Thank you for that. Okay, switching gears again to vitamin D. So there's a few questions about that. Specifically, is there a recommended form to take vitamin D, chewable versus oral versus drops? And there was someone that mentioned that in RRMS, if the vitamin D level is around 400, should it be continued or stopped? Not sure if that makes sense to you.
Well, in terms of our recommendation for vitamin D, there's certainly a strong association out there between, people that are just in the population, and if you measure their vitamin D levels and you look at their risk of multiple sclerosis, there's a very strong correlation between people with high levels of vitamin D, they have a lower risk of multiple sclerosis. So that's definitely an association. Sometimes it's a little bit hard to tease out exactly what factors go into that. I mean, are the people with multiple sclerosis staying indoors more because maybe they're not feeling as well, and so therefore they're not exposed to the sun, and they have a lower level of vitamin D than the average population, and that's pulling down the numbers in the multiple sclerosis group, whereas they're more elevated in the group without multiple sclerosis. And so it could be a chicken and egg sort of phenomenon, but it does look like there is a strong association with exposure to sunlight combined with vitamin D and risk of MS. So there's strong evidence just in terms of observational studies that that's the case. So far, there hasn't been a lot of strong evidence from randomized control trials. There are larger trials that are currently ongoing, and their results will be available in the future that may shed further light on this. But right now, what we're recommending is vitamin D 4,000 units a day. There's some evidence to suggest that maybe vitamin D3 might be a better form to take vitamin D in as opposed to vitamin D2. But overall, the recommendation is for vitamin D 4,000 units a day.
And I'm going to build on that question, Dr. Parks, whether it's recommended by you and others to have or to be tested, like have a neurologist or do a test periodically on your natural vitamin D levels, or if just should be blanket statement, everybody should be getting minimum 4,000 units.
Right, and that's a little bit tricky to answer. It is a case-by-case basis, and different practitioners do have different practices in that regard. It is at the center that I practice at. It is unusual to test for vitamin D. So most patients would be on it without having a serum blood level to know what their vitamin D is. But that practice does vary from center to center, and certainly at another center that I practiced in, they did check vitamin D on a semi-regular basis. The objective, or at least what's been written in the guidelines, is to achieve a vitamin D level in your blood of greater than 100 nanomoles per liter. So generally the dose of vitamin D that leads to that level in the blood in the typical person is between 2,000 and 4,000 units taken as a supplement per day. So as a general recommendation, it would be vitamin D 2,000 to 4,000 units per day, and in general we recommend to our patients 4,000 units a day. Okay.
And sorry, and going back, I'm not sure if you, because I threw a lot of questions at you, if you addressed whether the format it comes in, whether drops or oral or chewables, does that matter with vitamin D?
No, they should all have the same content of vitamin D. It would just be a matter of looking at the units that are administered as that dosage, and it shouldn't really matter the medium through which you get it. You just have to be aware of the form that you were taking, how much vitamin D that dosage contained.
Right. And can vitamin K along with vitamin D in drop form help?
I'm not familiar with the role of vitamin K, so maybe that's something that I'll use as a learning issue for myself after this talk. But certainly it's not something that we've been recommending in clinic, and it's not something that I've heard of before. We're certainly not implementing that in any of the places that I've worked. So definitely, if there's research out there on it, I haven't seen it, but it definitely hasn't made it to prime time in terms of being a clinical recommendation that we're making.
Fair enough. The person that asked, he or she commented later on, it may help in reducing deposits in blood vessels. That is when vitamin K may be helpful. So.
I haven't heard that, but I will look into that and see what is out there on the topic of vitamin K and multiple sclerosis.
Wonderful. Okay, so I am going to go back a little bit more into supplementation as well, and this individual is asking about if you know of any evidence with respect to turmeric supplementation with respect to pro-inflammatory states.
Mm-hmm. And that's an interesting question. There certainly has been research conducted into turmeric and curry regarding whether that influences the inflammatory state. But again, it's something it's been looked at the molecular level. I'm not aware of any rigorous trials that have investigated that. So again, I mean, in moderation, if you use it as part of your diet and you cook with those spices, it's probably not something that's going to harm you. But at the same time, there's not a lot of evidence to support its use. And again, it's not something that we're recommending in clinic.
Okay. And continuing on with the supplementation theme, can you speak to supplementation of magnesium? This person also says, with referencing magnesium, that how much should a person with anxiety and MS take?
Well, magnesium certainly has quite a few applications in neurology. Certainly, if someone is experiencing muscle cramps, what we typically do is test for calcium and magnesium, and certainly if those levels are low, but even if they're in the normal range, sometimes taking calcium and magnesium supplements can be helpful. Other roles for magnesium can be in the prevention of migraine headaches. So there's certainly been evidence that magnesium supplementation, so taking magnesium on a daily headache, reduces your risk of migraines. And then there's been certainly in higher doses, magnesium's been used for treatment of seizures, like seizures that might come along with pregnancy, so eclampsia. So magnesium has lots of roles in neurology. Again, it's not something that we're recommending particularly for multiple sclerosis, but certainly I've used it for all of those applications that I talked about.
Thank you. So we're going to shift gears again, and this individual is asking about your observations with respect to vegan versus vegetarians versus meat eaters, and how that may impact the prevalence of MS.
So again, it's difficult to say which diet is optimal. I mean, there's not a lot of rigorous evidence out there that would support any of the three specific diets I spoke of in terms of having a well-designed randomized control trial that shows clear evidence of benefit to multiple sclerosis patients in the group that followed the diet versus the group that was assigned to kind of a placebo treatment group. So that evidence doesn't really exist. In terms of what is out there, so again, diets that are low in saturated fat. There's been observational studies, like in the Swank study I presented, that maybe people who follow the diet did better in terms of survival than those who didn't. But again, there's a lot of self-selection issues there, and it's difficult to attribute those gains just to the diet itself. So I'd say there's really not a lot of evidence out there to support whether a vegan or a vegetarian or a carnivorous diet is the best diet for a person with multiple sclerosis. I would say again that Canada's food guide is probably a good model to follow. So that's a balanced, healthy diet that's going to be good for overall health, even if it doesn't have a specific effect for multiple sclerosis.
Thank you. So I'm going to circle back a little bit to our biotin discussion, and this one individual just wanted a little bit of clarification on what specifically is biotin, and can they buy it in a vitamin supplement, or is it found in food, or both?
Right. So biotin is a vitamin, and it acts as a cofactor with enzymes that are involved in the synthesis of fatty acids, including like fatty acids that might make up myelin, so the substance that's broken down in multiple sclerosis. So if you think of what a cofactor is, it's kind of it's kind of like the gas in a car. So the enzyme might be the car, but without the cofactor, the gas or the biotin, the enzyme just won't run. It's not going to work, and it's not going to facilitate the reaction. So biotin kind of acts like the gas in the enzyme reaction and allows the synthesis of fatty acids. So that's where this theory may have come from in terms of supplementing biotin. Now, what kind of foods contain biotin? So there's a number of foods. I mean, it can be found in quite a few things. I mean, eggs would be a good source of biotin, as well as nuts and even meats. So various foods would contain biotin. But the interesting part about the dose, and I'm not entirely certain how the dose was arrived at in the high-dose biotin trial, but it's many, many times the recommended daily amount of biotin. So if you look up in dietary guidelines how much biotin does a person need to function, it's on the order of micrograms. So they say 40 to 100 micrograms per day, which is 0.04 to 0.1 milligrams per day. And in the trial, they looked at 300 milligrams per day administered as 100 milligrams 3 times a day, so 300 milligrams a day. So even if you took the highest recommended daily amount of biotin, which would be 0.1 milligrams per day, that's still 3,000 times the recommended amount of biotin. So that's quite an increase over the recommended amount. And I'm not sure how that dose was arrived at, but that is the amount that was used in the randomized control trial that's out there on biotin.
Thank you.
So then, where do you get it? So biotin is sold over the counter in pharmacies in the vitamin section. The issue that people would find if they went to the store and tried to take the dose that's in the trial in the forms that are sold at the drugstore, or over the counter at least at the drugstore, would be that the typical biotin pill would come as 1,000 mcgs, so micrograms, or maybe even up to 5,000 mcgs a day, mcgs as a tablet, but that only translates to 1 milligram. So they'd be taking hundreds of pills per day to reach the doses that were administered in the trial. So if you were to take 1,000 micrograms, that's 1 milligram as a tablet, you would need to take 100 tablets 3 times a day to have the intake that was evaluated in the clinical trials. So that's kind of prohibitive in terms of biotin might be the only thing that you were able to eat because you'd be full if you ate that many pills, and it would be very expensive because, of course, you'd be buying basically a bottle or more a day. So that's one of the reasons that it can be difficult to obtain biotin, and for patients to kind of adopt taking biotin, at least in the amounts that have been studied on their own. Biotin can be compounded by a pharmacy. Certainly I've seen individuals who are on compounded biotin, and then it's basically the dose of 100 milligrams is compounded into a single capsule. That can be something that an individual could talk to their physician about, but that would have to be formulated at a pharmacy, and you would need a prescription to do that.
So we have a few more minutes left, and I'm not going to be able to get to everyone's questions because there's still quite a number of them that are remaining, but I'm trying to do my best to get a variety of different ones. And a question came up about probiotics, whether it be beneficial for somebody that has MS, and if there were specific ones that would be more beneficial than others.
So that's an excellent question. I didn't address that in my talk, but there's more and more research being done all the time on the microbiome, which is basically the complement of bacteria that exists in your gut. And there is evidence to suggest perhaps that multiple sclerosis patients do have a slightly different makeup of in their microbiome, so the types of bacteria that exist in their gut, than just the average individual that doesn't have multiple sclerosis. Certainly, there's research into that area looking at what the makeup of bacteria or the microbiome is in multiple sclerosis patients and whether or not probiotics may be useful. But it's still in the early stages, and at this point, we're not making a recommendation about probiotics or any specific probiotic.
Thank you. And I think we may have time for 1 or 2 more questions. I do want to, at this point, make sure that there's no one sort of patiently waiting on the line if they'd like to ask over the phone. It's *7 to unmute your individual line, and only those who want to ask a question to unmute. Okay, so I'll take that as no. People are content with asking over the chat pod. So perhaps we'll do one more here, and I'm trying to see if I can find one that's a little bit different from everyone else's that we haven't already addressed. Bear with me here. I guess we can speak to a leaky gut or a loose intestinal barrier, and there were some questions about whether having a leaky gut and whether that can cause foreign particles to get into the body, causing some antibody production that may be able to penetrate the blood-brain barrier and impact either a diagnosis or symptoms of MS. Any comments to that?
So I think that probably plays into the research that's being done on the microbiome and what the barriers are between the gut and the body and the brain. And that there's, certainly the microbiome is a very active area of research, and I think there's going to be more to come on that field.
Okay, well, I think that's a good place to end because we have come to the end of our 90-minute session here. I do want to thank everyone for their participation this evening. It always makes for a wonderful event when you have this type of interaction and lots of questions and discussion. And, of course, none of this would be possible without our presenter. So, Dr. Parks, thank you so much for your time tonight. I do have 3 reminders that I would like to pass on. The first being that a recording of this event will be available on the MS Society of Canada website within a week or so. I have posted that website also in the chat pod on where you can access the other previous events up till now. 2, the event this evening is the 7th of an 8-part learning series brought to you by the MS Society of Canada. The 8th and the final session is actually going to be conducted in French in October. So if you are fluent and or interested in participating in that, keep your eye out. And then third, you will receive an email very shortly requesting your participation in a survey from MS Canada, slightly different than the questions that we've been asking this evening. So do keep an eye out for that in your inboxes. I'd like to invite my colleague Monica Jordan from the MS Society of Canada just to say any final words. She's on the line as well. Monica, are you there? *7.
Thanks, Jillian. Thanks, Jillian, and I just echo your appreciation to Dr. Parks. That was a wonderfully informative talk. Sounds like lots of lively questions. And just as a reminder, the MS Society does provide information and support via our MS navigators. So you can certainly reach out to them. If you go to our website, then you can see contact information if you do have any additional questions about the latest research or living well with MS. And thanks everybody for dialing in and participating so actively. Have a great afternoon or evening, depending on where you are.
Yes, thank you very much, everyone. And Dr. Parks, any final words from you before we head out?
Well, I want to thank everyone for tuning in tonight, and I hope that there was some insight into a neurologist's perspective on the interplay between multiple sclerosis and diet and supplementation. And I hope I've given you an evidence-based approach on how to move forward with these issues surrounding diet and supplements.
Wonderful. Well said. Well, thanks, everyone. Have a wonderful remainder of your day, no matter where you are in our big country of ours. And thanks again for tuning in, and have a great night. Take care, everyone. Bye-bye.